the Heart Institute for over 20 years. He specializes in nuclear cardiology. So please welcome Dr. Mani.
Thank you guys for coming over. It was supposed to be a Zoom meeting from my office, but I thought, it's better to come over here because something's going to go wrong with me in the office. But I think I'll probably sit down and handle this because our clicker is not working.
So let me apologize, first of all, if my phone rings, just in case. So it's got the volume on.
Can you hear me? Or okay. So yes, we are in a COVID pandemic, but February is our month, and we always go out to the community. And every year we actually go down to the escapees, to the Alabama Coshata, and we've started doing this at, I think we came here last year too. And the relevant cardiovascular topic for me today is what COVID does to the heart. Now, just today we reached 500,000 deaths of COVID. And that's a kind of infamous record. Now, look at the cardiovascular mortality every year. 500,000 people die of heart disease every year too. And you can see how this whole thing is interlinked. And we found that 3 or 4 diseases in cardiovascular systems make the COVID susceptible, make the COVID patient susceptible to not just a bad COVID infection, but death. If you have heart failure, if you have coronary disease, if you have diabetes and kidney problems, you're more likely to have an adverse effect from COVID. And that's what stark numbers are telling us. If you have an ICU patient who has coronary disease and just get COVID, you have a 25% chance of dying, not just a bad disease. And that's how the mortality is soared. That's how we have a 500,000 death of COVID-related illness. So when you have how does this go ahead? I don't know. So, and this is another slide that gives you it's a very busy slide, but don't worry about all the gibberish there, but basically it's telling you what COVID does to the body. Unfortunately, it's just a high inflammatory response, which causes most of the damage. And the damage can be mostly in the lung, and that's what the pulmonologists have been very, very busy. When this whole thing started, we had a shortage of what? Masks. We had a shortage of personal protection. We had a shortage of everything. We had ventilators. Do you know what the shortage is now? Lung doctors. You have a shortage of personnel to take over the enormous brunt, that hospitals are taking in. Even in our little hospital over here, I have people from New York who come and work. We have intensivists who work from New York to take over the weekends. We have a shortage of personnel now because this has been a huge burden for the health system over here. So other systems also get affected. If you have underlying cancer or kidney disease or diabetes, they have around a 7 or 8% chance of having a bad outcome with COVID. But the top number is cardiovascular. It amounts to almost 25 to 40% of bad outcomes in COVID. So that's why we are, creating an awareness of if you have coronary disease, or if you know someone, your loved one or colleague with coronary disease, with congestive heart failure, make sure he doesn't get COVID. Because that is the need of the hour. Keep them safe, keep the social distancing, keep the mask on, and get a vaccine. These are the 1A, 1B, 1C categories who need a vaccine. So, if you list up what COVID does to the heart, the little spiky little thing, that little furry ball, is not a nice thing to have. It looks nice, but it's a lethal kind of virus. It's not a new virus. In 2002, we had the SARS epidemic, and luckily it was more concentrated in the Singapore, Southeast Asia. I have friends in Singapore who lost their respiratory tech to SARS. And then we had the Middle Eastern MER called MRSA virus. That was also pretty lethal, but short. It did not spread like this. The problem is this virus is so infectious that it goes through the population like grease lightning. And that is the problem. When a large burden of virus comes in and affects the community, that's why we like the social distancing. We don't want crowds, you don't want to, sit in in large stadia. And we can do it, we can beat it by increasing the herd immunity. What does it do to the heart? First thing you see is that this man has a very, very fast heart rate. He'll be complaining of fatigue more than anything else. And because it's an inflammatory virus, you'll get pleuritic pain, not the typical chest pain of a heart attack. You'll get the rubbing, and it's hard to breathe. And serious enough, it actually inflames the heart muscle, makes it flabby, and even get a cardiomyopathy, which is, a disease of the muscle. Of note, we have seen the virus causing a lot of clotting problems. It is a thrombogenic virus. It means you can get both venous clots and you can get arterial clots. And that is a huge problem because you can get anything from a heart attack to DVT to a lung clot or a stroke. When you have a virus causing the whole response is thrombogenic. It's a huge problem. Do we get more heart attacks in COVID? Yes and no. The number of people who died of a heart attack in this COVID period has increased at home. Why? Because they did not want to come to the hospital. Constrained, they don't want to go to the ER because of this fear of COVID. And a lot of people died at home. If you come to the hospital, you probably still have a good chance. So if you have a heart attack, call 911, get to the hospital. It does not matter. We take the precautions in the hospital to keep you safe. And yes, it's an inflammatory disease. Myocardial infarction is a disease of plaque. In the blood vessel, it's plaque. If any inflammation comes on that plaque, it ruptures and causes a heart attack. So yes, COVID can cause heart attacks. But the main problem is congestive heart failure. If you decompensate and if you can't breathe with congestion in your lung and COVID hits you, that's a double whammy. And it's hard to get back after that. Cardiogenic shock is something that's real ominous, and not many people recover from that. If they come with no pulse, no blood pressure, with an oxygen saturation of 60, blood pressure not recognizable, that is a very difficult patient to really get, salvage. Again, the virus looks very pretty, and it's almost like spring is here. Remember, there's no difference. People said, oh, the spring will come and then the virus will go away. That's flu, not this. This has been at our heels for the whole year round. Now, if you see that lung, that's what a typical lung looks like in COVID. That's a CAT scan of a lung. And you can see that white ground glass kind of appearance. That's what it does to the lung. Why? Because the inflammation is so great, it just pours in fluid and inflammatory material, and ultimately you can't get oxygen. That's what the lung looks like. This is another picture of the lung, but if you see those these, what is pointing out to you, those are blood clots in the pulmonary artery. That's as serious as a heart attack. And COVID does that to the lung vessels too. The two problems, one inflammation of the lung itself and the blood vessels. So, third thing is the lethal problem in COVID is arrhythmias. Now remember, when you have a heart, it's designed to work for a lifetime, and you get an onslaught, it's almost like a drive-by shoot, you know. It gets so much of inflammation that the muscle goes irritable, and you can get lethal arrhythmias. Arrhythmias can kill you at home, like VTAC. That's how a heart attack usually dies at home. You get an arrhythmia, which kills you. Same thing happens over here. When your heart is so unstable, you can have problems. The biggest problem is we don't want to add more problems. And if you remember, there was this talk about giving hydroxychloroquine and all the sorts of medicine which have no proven value. We were very concerned because you add Zithromax or Levaquin with hydroxychloroquine, and you can get a lethal rhythm, like that rhythm, which will kill you. So you don't want to add more, fuel to the fire. And there's no evidence that hydroxychloroquine even helps. The death of stays are the same. No, nothing at all. So there's no recommendation in cardiology to give any of the drugs which are touted by all sorts of unscientific research. So that's what kills you, the rhythm. So you don't want to keep the rhythm as pristine, as normal as possible. You don't want to add anything to it, make it unstable. There are two types of rhythm. One is the fast bang, 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 bang rhythm, which usually kills you at home. Now if you look at the corner there, that's a slow rhythm. See a big pause there? That's the kind of rhythm people in-house die with. So we've seen people in-house dying of COVID. It becomes so bad on the inflammation is so bad that the whole conduction system, which is actually the wiring of the heart, is totally frayed, doesn't conduct, and you die with a slow heart rate. So both fast and slow. That's what you see when the virus hits you. So, do not ignore your heart symptoms. If you have chest pain of any sort, and it always happens on a Friday afternoon or a Saturday when there's no doctor, no office open, go to the emergency room, however crowded it may be, or an urgent doc, or some place where you can get an EKG and take your enzymes. Because the care is critical. We can save, lives by doing it timely. You have to, so the old victims still stand, whether you have, even in the COVID state. But you got to be careful. You got to go with the mask off. Remember, it can cause stroke too. I told you, it's a thrombotic disease. So if you're having a loss of, you're passing out, or your balance is gone, and you're tingling, and you can't move your arm, you may be having a stroke. That can be cured if you reach within 4 to 6 hours. So do not ignore the signs. You have to call your doctor Monday to Friday. You're welcome to call us. That's something which the service we offer. Now, what happens to the serious people? When this started, everyone just blew it off, including the medical community. And we thought, okay, another virus. Now, what the heck? I remember I was in California because my mom wanted to see her classmate she hadn't seen in 40 years. And my mom is 87 years old. And so I went to see her in California. And that was when the first cases of COVID were described in America. And where did they start? In a nursing home. And I see even time again, we treat a patient here, hip fracture, and the next thing you write is, rehab. Where do you go? Nursing home. And we have patients who were discharged in a proper state here, dying of COVID back in the nursing home. So you've got to rethink this whole thing. The protocols don't work anymore. Yes, the 911, heart attack, stroke, that remains the same. But when you're in a hospital, you've got to understand the environment outside. In the hospital, we can keep you safe. And there are a lot of things which can keep you safe, including the airflow, changing the ventilation, oxygen, but not when you go outside. So all the good work which poor guys, they repaired her hip and she was dead of COVID in a nursing home. And And that's really, we've got to really think that. It's just not the same hunky-dory system anyway. The new sense of normal, we've got to rethink the whole thing. People with serious lung problems. I had a report from Chicago where the young lady recovered from COVID but with no lung left. Luckily, she got a matched lung transplant, and she's alive today with new pair of lungs. That's how bad it can go. This is young. This is a 30-year-old with no comorbidity, other than maybe crowded housing. So that is the last resort. And here, we give the heart and lung a rest by various, we don't have it here, but down in medical center, we have sent people from here who ultimately we could not salvage, his or her respiratory system, and we use extracorporeal oxygenation. It means you give the heart and lung a rest by putting tubes and getting oxygenation outside the body and let the lung heal. It's called ECMO. And there are methods we use that. Remember, COVID affects mostly the right heart of the lung. Heart attacks and all on the left side of the heart. The right heart the right heart pumps blood to the lung. The lung is so like solidly, rock solid because of inflammation. The right heart fails. It cannot pump against that resistance. We are an oil country. We talk of pumps and resistance. If your resistance is this high, your pump is going to fail. That's what happens to the right heart. So what do? We do something called an impeller. And this is available even in Lufkin. We can put a catheter through the groin, and then we put it into the right heart. You see that tube going to the right heart. And that actually gives a little oomph for the right heart to pump, because the right heart is failing. So these are little things which you can do, and we can wait till the lung recovers. So, we've had COVID for a year, more than a year now, almost a year. So what happens in a heart attack? We have a STEMI. A STEMI means full-blown heart attack. Nothing changes. He goes to the cath lab. Unfortunately, half the cath lab was down with COVID. So there's constraints on what is available. Cath labs were chock full not because of just the COVID, but people getting affected, hospital workers, frontline workers getting affected with COVID. There was one time when in Lufkin, half the people working in the cath lab had COVID. So you can understand the burden on the health system. But when you have ST elevation MI, with a tombstone kind of STs, nothing changes. You take them to the cath lab with full personal PPE, which means not just mask, you're fully covered. And they also got to be fully covered. We usually don't wait for a COVID test for an acute full-blown heart attack. Why? Because there's no time. You have got to open that muscle in 90 minutes once it reaches there. So you don't have time for this COVID result to come back. Often it comes back positive, then you're protected because you had this mask and your PPE. So you go with full protection. That has changed. Now, if you have a non-ST elevation, the smoldering MI, the stuttering MI, which is a myocardial function in progress, you have time. Now, this is new. Previously, I had ST elevation or ST that goes, but a non-ST elevation MI, which is a stuttering MI, we used to just stabilize him, make sure he's all right, make sure his troponin is all right, and then transfer him the next day. Now, I may not even transfer him, because if he's stable, he can go outpatient and get an outpatient cath later. We just let it settle. Previously, we were not doing that. Any one of the troponins was sent to the cath lab. Now we can't. We don't have personnel, we don't have resources, we don't have enough people to take care of these problems. If you are in a red hot zone, in many areas of America, you may get care much later. And that's what COVID has done to us. Resources at a stretch. And we're still in America. Well, a little freeze taught us how we could, all go, completely searching for water. But things happened. And we need to take a stark look at the whole thing and rethink our protocols. So what do? We have echo, we have troponins. Now there are certain biomarkers for COVID. We usually use D-dimer and troponin. Troponin is a marker for the heart. But we've seen every COVID patient has high troponin, high D-dimer. It's an inflammation. It's a sign of inflammation. So based on the troponin, we know up and down, we know that it's working. So that's exactly how a synopsis of how the heart gets affected in COVID. Sometimes it's just the heart is so overworked that it sort of just gets turned. We call it takotsubo, or stress-related cardiomyopathy. The heart just doesn't work because of so much stress. For some reason, it's seen in women. I don't know. Do you guys have more stress? No. We have stress too, but it's seen mostly in women. High catecholamine, stunning of the heart. Now this is a good prognosis because we know that's going to recover, and we have to just follow that, give medications and stuff. These are all things that you find. But main problem is inflammation of the vessels, of the muscle. So if you have again I told you, if you have a heart failure patient with COVID, 25% of them die. It's as stark as that. So if you have heart failure patients in the community, it's our job to keep them protected. They should not get COVID. Protection is paramount. And how do we protect? Well, we have different masks, and they throw all these little numbers. And, oh, did you get your PPE? Or what's PPE? Anyone knows what's PPE?
Personal protective equipment.
Good. And put all the others. What's AGP? Aerosol generating procedure. Now here's a classic scenario. Someone dies, you start CPR, you got a code, and then previously we used to just code them, CPR, ACS protocol, there's all sorts of blood and guts all over the place. What's changed now? COVID patient. Number one, we intubate right away. We don't wait for intubation until that, because if you're going suctioning and ampoule bagging, there's a lot of aerosol in the air. You should be in full protection gear, full PPE when you run a code for these patients. And all this costs us resources, it costs money, it costs, you have a lot of expenditure when you start, treating all this, with so much of equipment. So that's number one, intubate the patient so that there's not much of aerosol, all over the place. That's the CPR rules have changed when you have COVID. So what is the FFP? Let's say FFP3, FFP5, FFP9. What's this mask called?
N95.
Yeah. And depending if you have straps over here, that's N95. If you have straps over the ear, it's called K95. Right? Now N95 is the way to go for most people who have, people like us who go into ERs every day. When you're on call, you go to 3 different ERs. So we wear N95 when you're going to high areas of exposure. But otherwise, the ordinary mask is fine. Now people who are in really, in COVID units, they wear something called as N99 mask. This girl is wearing an N99 mask. What does it differ? It's got 2 filters over here. And it sort of gives you additional protection on that, because air goes in and out only through those filters. So there are different types of masks. Now what about ventilators? Remember the first few months they were tubing everybody, and a lot of people are dying just because of complications, barotrauma, because of the ventilator. We didn't have ventilators. When the ventilators came, we were putting everybody on ventilators, and we were killing more people. So now we've come full circle. We do not intubate until it's really necessary. It may take 2-3 weeks of treatment. So how will you give the oxygen if you don't have a ventilator? You have these little things called Airvo, you see these names being floated out, Airvo or Vasotherm. Beautiful concept. It fits over here, right here. You create an air pool in the oral cavity of high oxygen, and you let it go in and out. It's a simple concept, but it prevents the barotrauma of intubation, prevents pneumonia of the intubation. 15% of the time we can avoid, any problems of what comes with a ventilator. And we have taken people out just on Airvo. So see the first patient there? It's a little tube going in there with high flow, extremely high flow. You have sometimes like 80 liters of oxygen. Well, you better have oxygen in the tank when you're using that kind of oxygen. But we do, and that's available. And we have taken people out just on Airvo without intubation. Normally, in any respiratory failure, this would have been intubated a long time ago. But we are not intubating for a reason. It saves lives. So, the response level for heart attacks remains the same. Nothing has changed. You go to the cath lab if you're having a full-blown heart attack. For a non-full-blown heart attack or a non-STEMI, stuttering heart attack, it has changed. You'll be stabilized in the hospital where you are, and make sure you're stable, and you may have a heart cath maybe a week or 10 days later because of the resources. That has changed. You don't jump anything. Anyone unstable goes straight to the capital. So these are changes which we are doing. We are doing stress imaging to risk stratify. You have a small bump in components. They say, oh, it's heart attack. Yes. What type of heart attack? Maybe just a demand heart attack. The heart's training for oxygen. You do a stress test, make sure the circulation is good. You can wait. So these are changes which are put in place for a reason. So, yes, we are socially distanced. A lot of our routine things which we did have canceled. We don't bring people into the hospital for no reason, for just a visit sometimes. We talk FaceTime. We do a Zoom or what's called doxy meeting, and we just talk to them. Anyone with a smartphone, we can communicate. Simple. They just want their medications renewed. You don't have to come to a hospital. You don't have to come to the office for that. So we have changed the way we practice. Period. Now, we have used devices. Now, someone comes with an arrhythmia or says, hey, look, my heart's running away. Normally, we bring them to the hospital, put a hold around, and then when they come back with the thing, now I just mail it to them. It's only so small. You just tape it on here, I get a satellite image every day. So technology has helped. So things have worked out for them. The change has actually helped in streamlining therapy. So a lot of online remote sensing things have been done because of COVID. And that's another change we have done. Otherwise, you'll be overwhelmed. Now, why do we cancel all the elective surgeries and procedures when the going is rough? Because you won't have a bed. If you have an outpatient surgery, like he's waiting for a little hip replacement which has been scheduled, he can probably wait another 6 weeks because in a hot zone. Now, if the going is good, and luckily, since the last week onwards, it has plateaued and it's hopefully in the down slope now, nationwide, of the number of COVID, infections. So once you turn the tide, we get back to the normal schedule. But we are postponing elective surgeries just in case we need beds. Health protocols demand that we stay safe. As I said, we have a shortage of doctors now because, there are offers on every weekend. We're doing intensive, and critical care consults remotely to other towns too, who need a doctor. So that's what's going to happen, We have to isolate the vulnerable population. The retirement, this is a retirement community. Most around Livingston is a retirement community. And we got to really isolate who's vulnerable and get them protection, get them the vaccine. That's the only way it will work. We have developed new protocols just to help, do that. I'm going to stop here, and you have any questions of anything which concerns you? Yes, sir.
For someone that's already tested positive and has positive results or is currently positive, are there any type of therapy or medications or anything that you would prescribe, whether they're prescription or over the counter, to treat that patient?
Well, that's a nice question, because it depends which part of the world you are. If I go for a vacation in India, they give you a little package of ivermectin, which is used for a parasite. They give you zinc tablets, which is universal, and they give you a Zithromax and say, okay, take this for 1 week and stay home and look at your saturation. In America, if you have recovered from COVID, and you will remain positive for a while, because there's still fragments of virus in your system. So you'll still be positive. It may not be infective as such. What do you do? What I really recommend is chest physical therapy. We are proning patients. We are keeping patients prone. Turning them. Prone means they're lying on their tummy. It's hard to ventilate a patient when you're proning. But by proning them, the basal lungs come up and airflow becomes easier. So proning is, you can do it at home. You just have turn to your side, keep a pillow if you want down there. Chest physical therapy is what we really, because it affects the lung most often. And of course, you get back to you're extremely fatigued after COVID. And it sometimes, it sort of saps you. You got to start your physical therapy again. We advise you not to go to crowded gyms. You can go to a gym, finding out which time is nobody's there, but getting back with physical therapy. So the treatment is conservative. There's no medication. Instead, you can take zinc. We give zinc to everybody. Why? Because it doesn't hurt anybody, and it's pretty much benign. Doesn't interact with any of our cardiac pills. But other than that, there's no other protocol. Physical therapy, vitamins, zinc, deep breathing, proning when you're lying down. That's all the recovery is. And time makes a huge difference. You recover.
Would you also suggest the vitamins and zinc
Yes.
for someone that's trying to prevent themselves from catching
do it,
COVID, just
yeah.
to
Why
boost
not?
their immune system?
Absolutely. These are absolutely safe medicines to use. And if there's benefit, hallelujah. I have no problem.
That's the best thing to do, is just boost your immune system best you can.
Absolutely.
What have you seen personally as far as long-term effects from someone that has recovered? What have you seen personally?
We've seen, most of them come with extreme fatigue. The exercise tolerance is just worthless bliss. But after conditioned exercise, which we prescribe on 30 minutes of exercise, lane walking 3 times a week, and then later on coming to 5 times a week, a lot of them have done well. They come, after 6 weeks of COVID, they come to the office. We check the saturation, it's pretty good. We also ask them to check saturation when you walk. And it should remain good, above 90. If it's dipping down, that means we send them to a lung doctor. And he may have something. We give steroids. Steroids is known to help. In acute COVID, the one drug we have is steroids, which prevents the massive inflammation. So steroids is good during the acute phase, but you've got to taper it down. You don't want the bad effects of steroid afterwards. You've got to taper it down, and that's it. You have remdesivir, which is actually an antibody, which we use for our serious patients. And if you are in a bigger center, they get Regeneron, which is a whole potpourri of antibodies. These are for very sick patients. For just plain COVID infections, no, it's not indicated. They will recover. So that's how we do it. But if you have comorbid conditions, kidney problems, heart disease, transplant patients, they're all already immunocompromised. They're the ones getting into trouble. Diabetes. So these are the things we have to be careful about.
Any other questions?
so very much. That was very
Thank
informative.
you.